Professor Kjell Magne Tveit to present the National Cancer Plan of Norway. Yes, please. Professor Kjell Magne Tveit is head of oncology clinic at Oslo University Hospital and professor of oncology at the University of Oslo. He is also the director of cancer strategy of the Norwegian Directorate of Health. Please, Professor.
Thank you for the introduction. You hear me? Yeah, good. And thank you for this opportunity to tell something about Norwegian cancer plan and Norwegian cancer strategies during the last years. We had a cancer plan initiated in the 90s, and that was extremely important for a country like Norway. It had a significant impact on cancer treatment and care in many ways. And of course, an important reason for that was that specific governmental financial resources were put into that plan during those five years. I would focus on the impact of radiotherapy in Norway. At that time, many patients did not receive radiotherapy as they should, mostly in palliative care. So the number of radiotherapy linear accelerators has been approximately doubled during that time, and now we have 39 linear accelerators in Norway throughout the country. But the cancer plan also has a large impact on screening, on diagnosis and the multidisciplinary treatment of cancer in our country. At that time we had the breast cancer screening program and cervical cancer screening program. So then we had a national cancer strategy from 2006 to 2011 with also a more focus on prevention, treatment and rehabilitation. There was initiated a controlled study in colorectal cancer in one region of Norway, a randomized trial with fecal occult blood test and sigmoidoscopy. But it was implementation of a national program in one small area, and it's running just now. And there was also initiated establishment of national treatment guidelines for almost all cancer types, as I will come back to a little bit later. So now the new national cancer strategy starting this year was initiated by the Norwegian Minister of Health early in 2012. And the proposal for a strategy should be worked out by the Directorate of Health, and it started in May 2012. It should be a prolongation of the further expansion of the former cancer strategy, and it should also be developed through a close collaboration between the cancer care providers and the patients' organization. So the Directorate of Health then made a cancer report on current status, challenges and proposals for future initiatives in cancer treatment and care in Norway, finished by May 2013. And on this basis, the Minister of Health launched a national strategy, as you see here, on June the 4th, 2013 for these years. So the overall aims of the strategies are 5 altogether. The first one is to focus on the patients themselves, involvement of the patient and improvement in the patient-centered cancer care, with a stronger patient perspective in the national guidelines for treatment of cancer, a focus on information to the patients and the families, and the communications between patients and the healthcare providers, and also education of patients in hospitals and outside hospitals. The second aim was development and implementation of standardized treatment plans for all major diagnoses. It's a question of organization of coordinated patients' careers. It was The plan now is to start treatment of patients, 80% of the patients, within 20 working days from referral of a patient to a hospital. So this is now the way the government wants the Norwegian patients to be treated. 80% should start treatment within 20 days after referral to a hospital with suspicion of malignancy. Also, establishment of system for rapid and precise diagnosis and staging for patients with cancer. Close collaboration between the hospitals at various levels and between the hospitals and the primary healthcare services. Establishment of these coordinators coordinating the individual treatment plans for the patients is one aim just now. We had the problem with bottlenecks, I would say, in pathology, radiology, and endoscopy. So to improve the capacity within these three areas are very important in our country. And of course, the establishment of the multidisciplinary teams within the major cancer types, and also to establish multidisciplinary clinics, for example, by surgeons and oncologists meeting the patients together. And also strengthen the role of the general practitioner in the cancer care at various times of the treatment of the patients. The third one is the effective cancer prevention programs. So the goal is then of course, to reach the WHO's goal of 25% reduction in early death from non-communicable diseases within 2025. And to stick to the national strategy for cancer prevention, to continue the national population-based screening programs for breast cancer and cervical cancer, and also then to continue now and evaluate the screening pilot study in colorectal cancer being performed. Regarding the fourth aim of the strategy, overall improvement in cancer survival, the ambition is that Norway should be among the countries with the highest 5-year survival rate and the lowest cancer mortality. Yeah, I see there was one disturbing picture there. Today, I think we are among the countries with the highest survival, let's say, in rectal cancer, but we are not in lung cancer, we are not in prostate cancer, for example. Diagnosis, treatment, rehabilitation should be at a high international level. That's also an ambition, and also research in a country like Norway. And we have a national cancer registry. We are pretty proud of it, I think, but that should be further developed, and we should have quality registries for all the major tumor types linked to that cancer registry. We have some of them, but we should have more. Development of more quality indicators in cancer care. Today we have 5-year survival for 5 diseases, and we have a fraction of patients having treatment within 20 days after referral for true large patient group. But we should develop more of the quality indicators. Elderly patients should be focused on and adapt the national guidelines to the elderly patients, and there should be a continued focus on children with cancer, and a reduction in long-term side effects of the treatments would be a future focus. More regarding improvement in cancer survival, capacity and quality of surgical and oncological treatment. And there's a special focus on cancer surgery, and I think that's extremely important. Standardized surgery, the relationship between quality and volumes, robustness of the surgical teams, and so on. Radiotherapy equipment, updating, and we have some old equipment that should be should be replaced. There's more focus, I would say, now on proton therapy. Today, I think about 20 Norwegian children are sent abroad to have proton therapy. But there is now a political willingness and I would say a strong will to build a Norwegian center for proton therapy, although we are a small country. But proton therapy will come. But in the next years, we have to send patients abroad to have proton therapy. Effective chemotherapy, cost-effective chemotherapy, use of health technology assessments when introducing new treatments should be the ordinary way to implement new technologies. It hasn't been like that in the past, I'm afraid. And more research, clinical studies and translational research, and education and recruitment of specialists within different disciplines will be a focus. Quality of life of patients is the fifth aim of the strategy. Cancer rehabilitation, a focus on this aspect. Palliative treatment and care according to the WHO standard. Strengthening of education and training in palliative medicine in various specialties. And improvement in information to and follow-up of children of cancer patients. And focus on follow-up and supervision of families to cancer patients. Just a few specific comments. We have national cancer programs with specific guidelines within various types of cancer, and now we have close to 20 of those guidelines, and there will be developed more of them. And they need a continuous updating, and that's extremely important. So the guidelines available on the net should be updated all the time, and that's a tremendous job to do that, you know. But there are more aspects now being included in the guidelines, and that's aspect regarding the treatment plans with specific time intervals for diagnosis, staging, treatment, and so on. Focus on rehabilitation, late side effects, and also focus on elderly and GPs. Another comment would be that we now, this year, has implemented a national system for implementation of new technologies in the healthcare services. Just started. The system will contribute to prevent inefficient and potentially damaging technologies, and also phasing out old, less effective technologies. And to use the health resources in an optimal way. So health technology assessments before a decision and implementation in the national guidelines is the way Norway want to go in the future. Not only on drugs, but also on other technologies being included in cancer care. A system for medical equipment, drugs, and procedures and methodology, as I said. Screening, for example, should also be put into that kind of system. So the overall challenges in our country, and I suppose in many countries, is the increase in incidence and prevalence, the large patient volume we face in the future. In a small country like Norway, we have 30,000 new cases a year, and we have 220,000 patients living with a cancer diagnosis. And this will increase, we know. A challenge is also the new treatment options and the quality of the treatment in the future. How should cancer diagnosis, staging, treatment care, rehabilitation, and follow-up be organized? Education and training of healthcare providers in this situation. Need for clinical translation and research to test out the new treatment options. resource allocation, then implement the strategy. Will we succeed in 2013 to 2017 with this strategy, although it's ambitious and we would all agree upon? There are many partners, stakeholders that have to collaborate to succeed. Of course, the Health Ministry, the Directorate of Health in our country. We have the hospitals are organized within the regional health authorities in our country. The primary healthcare services will be involved, National Cancer Registry, Cancer Society and patients' organizations. And we have national cancer groups specific for different tumor types. We have also a national partnership against cancer where the different partners do meet to trying to coordinate this strategy. So the question is the political willingness, and will there be a financial resource allocation to this area to implement the strategy? How will the priority be for cancer care in the country? We have a new government in Norway, and I feel the signals from the government are very positive in that respect. This is Norway at the present moment. Thank you very much.
Thank you very much. And now the last presentation before the coffee break will be by Dr. Antonio Federici, who will present the Italian cancer plan. Dr. Antonio Federici works at the Italian Ministry. Oh. Sorry.
Not that long.
But I think the Italian cancer plan you will present, yes.
So good afternoon once again. I'm not Antonio because my colleague that all of you know very well because he was one of the main actors in this working group on the national cancer plans, unfortunately missed this opportunity to present, and this work is entirely up to him, so I'm here just as a speaker. I do not pretend, and I hope, as it happened this morning for the ministry, that my quality of voice and my presentation will be at least half of what he could have made. So apart from this, you might find this presentation somewhat different from others because, as you might know, we put in our national cancer plans also some aspect of general methods on planning that might be peculiar to this plan. So you will forgive me if we will have some minutes about these kind of aspects. First of all, let me say that despite we had before several planning documents on cancer, the present National Cancer Plan, which formally is in place from 2011, is the first time that the Ministry of Health is putting in place a large effort to involve stakeholders, including clinicians, professionals, civil society, and patient organizations to set up this plan. And it's the first time that this plan is discussed with not only at national level, but also with regional authorities. And this is also something that I will try to focus later on. Clearly, as for many other policy documents, this kind of planning bears from different sources. The first clearly is the actual evidence of having a large burden of cancer, despite, as we saw in the figures, Italy has not a prevalence higher than other countries, but the burden of cancer is in a large country as Italy is clearly one of the major public health challenges. On the other side, there is clearly an international commitment not only for having something done on cancer, but also for having a clear planning of the national resources. It is important also at the country level because Italy is made of 21 individual regions which are more or less fully responsible of their health planning. So it's very important for us to bridge inequalities that this kind of health organization unavoidably brings with it. The main goal of the plan is to have a comprehensive management of patients by the national health system. Despite the plan focus also on other aspects which are not specifically related to the national health system, clearly the main worries for us was to have a patient-centered approach. So clearly the ideal path that we follow in the description of the plan is to have an individual from the very beginning to a very late phase of the disease and try to imagine which kind of services the region should offer for all these various stages of the disease. The second aspect is to have, for the first time, shared priorities and common goals among all stakeholders, which was not something that was not very well done in the past. There are also some principles that I will not like to list in details. You can find it on the slides. That although they are not written explicitly in the document, they have been keeping strongly in account by the writers in order to ensure that all these principles that are fundamental to the national health system as a whole, but are particularly important for cancer treatment and prevention, would be applied also in the individual actions. The structure of the plan is at these following steps. First, making an individual decision on the areas of priorities, focusing effective needs within the selected areas. Last, identifying goals and definition of specific action plan for these individual sectors. I would not like to list all the contents. Clearly, as you can see in the slide, is a very broad spectrum plan and there are many individual items. I just want to focus your attention on the last lines where there is also a specific part dedicated to innovation and all those aspects of cancer that someone might consider specifically limited to research, but that in our opinion are and must be a fundamental part of any planning, because in the cancer field there is a continuous renewal of ideas, and it's important that the research results and the activities that are implemented in cancer research centers are as soon as possible transferred to the whole sector. Many areas of the plans are clearly cancer prevention, and in this case there are two different chapters. One is related to health promotion and primary prevention, which is clearly one of the priority of the country. The second one is secondary prevention. Tomorrow there will be a specific session on this, and I think also there will be the presentation of some data from Italy. The situation of cancer screening for some aspects in Italy is similar to that in Europe, in the sense that there are regions where these activities are long-standing, have been already in place since many years in a well-organized way, while for others or for some specific cancer screenings, this is unfortunately not the case, and there are still many inequities to be overcome. The second aspect is on control activities, and in particular the focus is on integrated cancer care and all the activities that are related to this overall wording. The third is dedicated to aspects that, as I mentioned, one can consider not strictly related to the activity of the national health system, but for us are very important, like research, the activities of cancer registries that luckily in the last few months have seen an important improvement in Italy due to approval of a specific law concerning data management, and also that it's not specific to cancer registries but has reached an important result, because up to a few months ago several of the Italian cancer registry could be considered brackets illegal under some of the various privacy regulations. Now we are very lucky that also on the inputs given by this plan, the legislation has been changed. Now there is still something to be done at the level of implementing this legislation, but we consider that an important step forward. This would not have been possible without this previous discussion in the preparation of the National Cancer Plan. There are also, at the end, some specific focus on specific themes that are not in the rest of the plan, and several of them, as you can see, are also part of EPAAC and of the next joint action. That means that we share a common perspective with the European discussion. Passing to governance issues, that I think is one of the peculiarity of this Italian plan. As I mentioned, from several aspects, Italy is a small Europe. So when we speak about what happens in Italy, I think it could be interesting to be referred of what could be in the future or is already a European discussion. First of all, Italy, and Europe, of course, is even more, is a decentralized country, and so this implies that not any decision can be taken at the national level, even if the government and the Ministry of Health can establish some very broad regulation and, say, principles to be adopted in a specific sector. We cannot oblige anybody to take decision, and even less to take budgetary decision. So it's very important that having a planning that is managed with the regions in order to ensure that at the level of implementation, what has been agreed could be really implemented. The last but not least, relevant importance of stakeholders has been of particular importance in this planning. A specific representative of the civil society and the scientific society has been appointed by the Minister of Health at that time in order just to write the basic elements of the plan with the ministry officer. Clearly, the plan and in general our policy represent an alternative to the classical vertical model of planning, because this is no longer possible, at least it's not in Italy, and I suppose it will never be possible in Europe with a very top-down approach, and so we somewhat happy to do that or not. We have to choose a very different model of interactions, which takes care of the different responsibilities and try to involve all actors in a perspective that should be managed in a common way. I do not have time to focus on this particular issue of stewardship, that I think most of you are familiar with this wording, which has not been invented by Italy, but is a clear commitment also by WHO. In particular, it was clearly stated in the Tallinn Charter on the National Health System. And I think stewardship is the right way to manage a situation where responsibilities are decentralized and are shared like it happens in our country. Clearly, it's a model that might have criticisms and may be somewhat to be tested as regards, and in particular its efficiency to produce decision in a short term. However, it has demonstrated in our country to make it better than attempts to do it in a different way and a more top-down approach. The plan also includes and foresees some tools for implementation. These tools are, let's say, still in progress in the sense that the technical documents are more or less ready, but since we want to adopt the same approach that has been used for the whole plan, these documents will now go in a discussion with a conference between the state and the regions, and we hope to have them fully adopted at let's say, at half of 2014. Three major tools for implementation are foreseen in the plan. The first is the guidelines for implementing oncology networks, and I will try to say a few words afterwards, just not because this might be entirely referred to the discussion of today, but because this is a bridge with one of the themes of the next joint action. The second is a document trying to identify, and this is a question that we had also at the lunch with the minister, which part of what we are doing now should no longer be in use and should be replaced by new procedures and by innovative ways of producing the same results. And this is quite crucial in a field like cancer, where innovation plays a key role in the field of also of healthcare. Last but not least, as it was mentioned also this morning by other speakers, there is the need of having an HTA document for the approach of the new kind of interventions, and particular for new drugs and strategies that will be implemented in the future. Just a few lines about this issue of the network. I think also EPAAC has produced excellent results in this. Clearly, there are different models of having cancer care. The most traditional, clearly, is that of comprehensive cancer care centers that are well established all over Europe. But unfortunately, despite we have also in Italy several CCC, this is not, in our opinion, the only way that we can offer to the public in order to be sure that we are really facing the enormous burden of diseases and the number of patients that should receive adequate care at a certain number of places. The hub-and-spoke model clearly is one possibility that is clearly also in place, in particular for pediatric cancer, is well diffused also in our country. But all of these models should refer, in our opinion, to something that is even more comprehensive and is more flexible and can be adapted to very different health systems and very different regional conditions. Clearly, there is no, I think, no final conclusion about this. We should work in networks, that's the only thing. How CCC and hub-and-spoke network can be included in a more comprehensive network, that will be a part of the next joint action. There are already clearly examples in Italy and also in other countries. We should try to work together in order, if possible. If we want to imagine a European cancer plan in the future, we should also focus on this kind of aspects that are clearly organization, but also at the end are responsible for the actual implementation of the treatment for the patients. Thanks a lot, and thanks.